Today, we're going to pull back the curtain on one of the most confusing and, frankly, misunderstood parts of medicine, diagnostic testing. What does a test result really mean? Well, let me tell you, the answer is probably not what you think.
Okay, just imagine this for a second. You go to the doctor, you get a test done, and you get that call. The voice on the other end says the result is positive. Instantly, your heart either sinks or it soars, right? It feels so final, so certain.
But what if I told you that in a whole lot of common situations, that single positive test result, it might not mean much of anything at all? That actually, the most likely thing is that the test is just plain wrong. And to really get why, we need to bust a few pretty big myths.
So let's jump right in with myth number 1. This idea that a positive test is basically ironclad proof that you have a condition. This might be the single biggest misunderstanding in all of diagnostics, and it all boils down to us mixing up two totally different ideas.
So the first idea is sensitivity. This is the number that test companies love to advertise. It answers a very specific question. If we take a group of people we know for a fact have the disease, how often does our test correctly pick it up? You see, it's a forward-looking question. It goes from the cause, the disease, to the effect, the positive test.
But that's not the question you care about, right? And it's not the one your doctor cares about either. You're starting from the other end. You've got a positive test and you want to know, okay, so what are the odds I actually have the disease? That is something completely different. It's called the positive predictive value, or PPV. It works backwards, from the effect to the cause. And that, my friends, is what really matters.
And this slide just lays that confusion right out in the open. We think we're getting the number on the right, how much we should believe a positive test. But the number we hear about is the one on the left, how good the test is at finding a disease it already knows is there. The secret sauce that connects these two is something called pre-test probability. Let's see how it works in the real world.
So let's say we do a really accurate test for lupus, an autoimmune disease, but we do it on someone who has 0 symptoms. The chance they have it in the first place, that's our pre-test probability, is teeny tiny, like 0.05%, because that's the rate in the general population. And surprise, the test comes back positive. So what's the chance it's a true positive?
Well, the chance that this positive result is actually a false positive is a mind-blowing 99.7%. You heard me right. In this situation, the disease is so rare that even a super-sensitive test is way more likely to pick up on statistical noise than it is to find the actual disease. That positive result, it's almost certainly meaningless.
Okay, but now let's flip the script. A different patient comes in, but this one has all the classic lupus symptoms: the fatigue, the joint pain, the rash. After a good exam, the doctor thinks, there's a pretty decent chance this could be lupus, and estimates the pre-test probability at around 30%. They ordered the exact same test, and it comes back positive again.
Now, that same positive result has a 74.6% chance of being true. The positive predictive value absolutely skyrockets. See? Same test, same result, but a totally different meaning. And that's the whole point. A test has no meaning on its own. Its value is decided entirely by the suspicion that came before it.
And that brings us right to our second myth, the idea that more data, more testing is always a good thing. You know, it feels right. The more we know, the better. But in medicine, it can often just lead to more confusion.
I love this quote from Dr. Valerie Vaughn. More information can overwhelm instead of inform. When you order a test on someone with a low chance of having the disease, just in case, you're not adding clarity, you're adding noise. You're inviting a false positive to come in and kick off this really dangerous chain reaction.
And it's called the diagnostic testing cascade. It starts with one unnecessary test. That test finds something weird, maybe a false positive. That then triggers another, more invasive test to check it out, which finds something else. And before you know it, the patient is getting risky procedures, they're filled with anxiety, and it's costing a fortune, all because of one test that probably shouldn't have been ordered.
And this happens constantly. It's why hospitals are now starting these diagnostic stewardship programs. They're trying to cut down on these super common but often useless tests, like doing blood draws every single morning in the hospital or doing brain scans for delirium when there are no other neurological signs. It's all about stopping these cascades before they can even start.
All right, myth number 3. This one's really baked into the culture of medicine. The idea that because some physical sign has been taught for 100 years, it must be reliable.
So let's talk about something called Beck's triad. For literally almost a century, medical students have had this drilled into their heads. It's 3 signs: low blood pressure, muffled heart sounds, and swollen neck veins that are supposed to be a classic warning for a deadly heart condition called cardiac tamponade. It's absolute textbook stuff.
But how well does it actually work in real life? Well, a 2017 study looked at patients who actually had this condition in the emergency room, and they found the full triad, all 3 signs, were present in, are you ready for this? 0% of them. Not 10%, 0. One of the most famous signs in medicine was a total no-show.
Researchers have a great name for this: romanticized semiology. It's a fancy way of saying that we fall in love with the story of a medical sign. The tradition, the authority, the history, it all becomes more important than actually proving, scientifically, that the darn thing works. We anchor on these old ideas, and they can really lead us down the wrong path. Okay, on to our last myth, and this is a really modern one. It's the idea that with big data and all this real-world evidence from millions of patient records, we don't really need those old-fashioned, expensive clinical trials anymore. But there's a massive fundamental difference. In an observational study, you're just looking at data that already exists. The patients who got a drug and the patients who didn't are different for a million reasons you can't see. But in the gold standard, a randomized controlled trial, you use the magic of randomization. You create 2 perfectly balanced groups by pure chance, which magically erases all those hidden biases.
And this chart just shows the danger so perfectly. The first bar shows that a bunch of big observational studies found that statins seemed to reduce cancer deaths by about 15%. Looked promising. But then they looked at the data from huge, high-quality randomized trials. That's the second bar. The effect? Exactly 0. Turns out, the real-world data was just showing that healthier people were more likely to be prescribed statins to begin with.
So, okay, we've just smashed through a whole bunch of myths. Where does that leave us? Well, it means we need to stop looking for simple, black-and-white certainty and start using a smarter, more honest toolkit for how we think about our health. And here it is. First, always think about the pretest probability. A test result is meaningless without it. Second, always ask, do we really need this test to stop those harmful cascades? Third, be a little skeptical of medical facts. Just because they're old, ask for the evidence. Fourth, for finding out what works, there's no substitute for high-quality randomized trials. And last, and maybe this is the most important one, we have to get comfortable with uncertainty.
Because at the end of the day, that's what medicine truly is. It's not this giant encyclopedia of facts to be memorized. It's a process. It's the art of using evidence skillfully to reduce uncertainty 1 step at a time. The goal isn't always about finding a perfect, definitive answer. It's about making the absolute best decision you can with the information you have by asking the questions that really, truly matter.